Good day to each and everyone. We are the Group 2 from Davao Doctors College BSN1 11F, and today we are going to report our worksheet number 5 in Anatomy and Physiology, which is all about our respiratory system. So for the first few slides, I am giving the floor to Miss Sofia Altera Bermejo to report her part. Sofia?
So, good day everyone. I am Sofia Altera Bermejo and I will be discussing the anatomy of the respiratory system. So, as you can see on your screen, this is for the anterior view. This is your superior nasal concha, your middle nasal concha, your inferior nasal concha. This is your nostrils, the hard palate, and the soft palate. This one is your palatine tonsils, and this one is your epiglottis, the bone, the thyroid cartilage, cricoid cartilage, and the trachea. So moving on to the posterior view. This is your pharyngeal tonsils and the opening of the pharyngotympanic tube, the nasopharynx, and here is your uvula, the palatine tonsils, the oropharynx. This is your laryngopharynx. This one is your larynx and your esophagus. Moving on to the next slide. So for question number 2, what is the significance of the fact that the human trachea is reinforced with the cartilage rings? Our answer for that is the cartilage rings in the trachea reinforce the trachea walls to keep its passageway open regardless of the pressure changes that occur during breathing. So follow-up question. Of the fact that the rings are incomplete posteriorly, our answer is the open parts of these cartilage rings allows the esophagus to expand anteriorly when the large pieces of food are swallowed. For number 3, name the specific cartilage in the larynx that described below. So, for the Adam's apple, our answer is thyroid. A lid of the larynx is our answer for this is epiglottis. Broader anteriorly is cricoid cartilage. Number 4. Trace a molecule of oxygen from the nostrils or nares to the pulmonary capillaries of the lungs. So, from the nostril goes to nasal cavity, to nasal conchae, to pharynx, to larynx, to trachea, to primary bronchus, to secondary bronchus, goes to tertiary bronchus, to terminal bronchiole, to respiratory bronchiole, to alveolar duct, to alveolar sac, to alveolar duct again, and lastly to alveoli. So moving on to question number 5. What is the function of the pleural membranes? Our answer for that is it produces a serous fluid that reduces friction during breathing movements, and it helps to hold the lungs tightly to the thorax wall, which keeps the lungs inflated. Number 6. Name two functions of the nasal cavity mucosa. Answer for that is it warms and moistens the air. Also, it filters the air that passes through the nasal cavity. Number 7. The following question refer to the main or primary bronchi. Which is longer? Our answer is left bronchus. So larger in diameter is the right bronchus and more horizontal is the left bronchus. Another one is the more common site where a foreign object that has entered the respiratory passageway is likely to become lodged. So our answer for that is right bronchus. Correctly label all the structures provided with leader lines on the diagram below. So for the structure of respiratory, this is your trachea, this is your superior lobe, This one is your inferior lobe. Lobe. Very low lung. This one is your segmental or tertiary bronchus. This one is the lobar or secondary bronchus. This one is superior lobe of the lung and the main or the primary bronchi. So moving on to the next structure, this is the terminal bronchiole, the respiratory bronchiole, the alveolar duct, alveoli, and the alveolar sac. So Miss Christine will continue discussing. So I'm passing the mic to Miss Christine. Thank you.
So thank you, Miss Bermejo. So for the next number 8, correctly label all structures provided with the leader lines on the diagram below. So we have number 1, the pleural layer covering the lungs tissue, which is the visceral pleura. And then number 2, the floor of the nasal cavity, which is the palate. And number 3, the food and fluid passageway inferior to the laryngopharynx is the esophagus. And then number 4, it flaps the glottis during the swallowing of food, which is the epiglottis. Next, number 5 contains the vocal cords, which is the larynx. And then number 6, the part of the conducting pathway between the larynx and the primary bronchi, which is the trachea. And then number 7, the pleural layer lining the walls of the thorax, which is the parietal pleura. And then number 8, the site from which oxygen enters the pulmonary blood, which is the alveolus. And then number 9, the opening between the vocal folds, which is the glottis. And then number 10, increases air turbulence in the nasal cavity, which is the concha. Next slide, which is number 10. So define external respiration. So the formal term of gas exchange, it describes both bulk flow of air into and out of the lungs and the transfer of oxygens and carbon dioxide into the bloodstream through diffusion. Next, the internal respiration, the exchange of gases as oxygen and carbon dioxide between the cells of the body and the blood by way of the fluid bathing the cells. Next, number 11, which the question is, does the lung inflate part by part or as a whole like a balloon? So our answer is the lung inflate part by part. And the next question, what happened when the pressure was released? So our answer is it deflated when the pressure was released. And the next question, what type of tissue ensures the phenomenon? So our answer is the elastic connective tissue. And then next, number 12, the tracheal epithelium is ciliated and has goblet cells. What is the function of each of these modifications? So our cilia, our answer is works together to push out the mucus and foreign bodies. Next, next goblet. Uh, our answer is goblet cells. Our answer is it secretes the mucus to trap inhaled foreign bodies. Next, number 13, the tracheal epithelium is said to be the pseudo, ratified and why. So the pseudo-ratified appearance of the respiratory epithelium is due primarily to variations in shape and positions of the nuclei of the different cells types throughout the epithelium. Next slide, which we have the diagram below, identify the alveolar, the epithelium, the alveoli, and the red blood cells. So bracket the respiratory membrane. So we have here the first thing we see, we have the alveolar epithelium. Then next, the capillary endothelium. And then we have here the circle one, we have the red blood cells. And then we have here in the center, which is the alveolus, which we have the most wide space inside the membrane. And then we have here at the side, which is the capillary endothelium, the basement membrane, and the alveolar epithelium, which we have the bracket, which is it is the respiratory membrane. And then below we have the elastic fiber, Next, we have the connective tissues, fibers, and then connective tissue cells, and then the last one, we have the monocytes. So, next slide. So, number 15, why does oxygen move from the alveoli into the pulmonary capillary blood? So, since the partial pressure of the oxygen is greater in the alveoli, so it moves according to the laws of diffusion into the pulmonary blood. Next, number 16, the last question for my part. So, what structural characteristics of the alveoli makes them an ideal site of the diffusion of gases? So, our answer is thin walls, membrane separating the air from the blood, and extremely large surface area. So, that is the end of my part. So, I will pass the floor to Miss Daniela Carion.
Thank you, Em. Good day, everyone. So, I'm going to report the respiratory system physiology. So, number one, base your answers to the following on your observation of the operation of the model lung. Under what internal condition does air tend to flow into the lungs? And explain. When there is an increase in thoracic volume and decrease in pressure. Under what internal conditions does air tend to flow out of the lungs? And explain. When thoracic volume decreases and pressure increases. Number two, activations of the diaphragm and the external intercostal muscle beings the inspiratory process. What results from the contraction of this muscle, and how is this accomplished? So the increased thoracic volume make diaphragm moves inferiorly, increasing the inferior dimension, ribs swing up and out, increasing the lateral and posterior dimension. Next slide. Write the respiratory volume term and the normal value that is described by the following statements. So, volume of air present in the lungs after a forceful expiration. So, it is the residual volume 1100 ml. Volume of air that can be expired forcibly after a normal expiration. Expiratory reserve 1200 ml. Volume of air that is breathed in and out during a normal respiration. Tidal volume 500 ml. Volume of air that can be inspired forcibly after a normal inspiration. Inspiratory reserve 2700 to 2800 ml. Volume of air corresponding to TV plus IRB plus ERB. So it is vital capacity for 4800 ml. Rec- record experimental respiratory volumes as determined in the laboratory. TV is 500 ml, ERV is 1100 ml, VC is 50 ml, IRV is 1900 to 3300 ml. Next slide. Number 7, where are the neutral control centers of respiratory rhythm? So it is in pons and medulla oblongata. Number 8, based on pneumograph reading of respiratory variation, what was the rate of quiet breathing? Initial breathing is 12 to 15 breaths per minute. Next is record observation of how the initial pneumograph recording was modified during the various testing procedures described below. Indicate the respiratory rate and include comments on the relative depth of the respiratory peaks observed. So, talking, respiratory rate becomes irregular when talking. Yawning, yawning is reflected by very deep, prolonged inspiration. Laughing, respiratory rate becomes irregular. Respiratory depth may increase or decrease depending on the nature of the laugh. Standing, regular rhythm and rate. Running in place, increase rate and depth of breathing. Swallowing water, respiration ceases during the period of swallowing. Coughing, respiratory rate becomes irregular and marked by increased depth of expirations during coughing. Lying down, regular rhythm and regular or slightly depressed rate and depth increases. Concentrating respiratory rate is regular unless punctuated by intervals of apnea in individuals who hold their breath when concentrating. So that's the end of my part. I am passing the floor to Faisal Bayani.
Thank you for that, Miss Carion. I am Faisal Bayani. And okay, 9. Student data. Breath holding interval after a deep inhalation. Our answer is 40 to 50 seconds. Length of recovery period. Our answer is 15 to 25 seconds. Breath holding interval after a forceful exhalation. Our answer is 30 to 40 seconds. Length of recovery period. Our answer is 10 to 35 seconds. After breathing quietly and taking deep breath, which you held, did you feel an urge to inspire or to expire? Our answer is urge to expire. After breathing quietly and taking deep breath, did you want to inspire or to expire? Our answer is to inspire. Next, number 10, observation after hyperventilation. The oxygen increases, carbon dioxide decreases. Next, number 11, blood CO2 levels, blood pH are related. When blood CO2 levels increases, the pH increases. Explain what changes might occur in the blood's pH if the breathing rate increased or decreased. Blood pH decreases because CO2 combines with H2O and produces carbonic acid, which dissociates and frees H plus ions, thus making it more acidic. Number 12. Length of breath holding after hyperventilation. Our answer is 12.3 seconds. Next, why does hyperventilation produce apnea or a reduced respiratory rate? Our answer is hyperventilation washes carbon dioxide out of the blood. Since carbon dioxide is the major chemical stimulus for inspiration, the desire or drive to breathe is decreased. Increased levels of carbon dioxide in the blood. Next, number 13, observations for rebreathing breathed air. There would be more oxygen and less carbon dioxide, resulting to an increase of respiratory rate and breathing becomes rapid and deep. Next, why does rebreathing breathed air increase the respiratory rate? Our answer is exhaled carbon dioxide accumulated in the bag at a greater level than normal air, stimulating an increased force or rate of respiration. Next, 14. Do the following factors generally increase? Indicate with I or decrease, indicate with D, the respiratory rate index. Increase in blood CO2, so our answer is letter I or increase. Next, decrease in blood CO2, our answer is letter I or increase. Increase in blood pH, our answer is letter D or decrease. Decrease in blood pH, our answer is letter I or increase. Did it appear that CO2 or O2 had a greater effect on modifying the respiratory rate? Our answer is CO2. Last, number 15, where are sensory receptors sensitive to changes in O2 levels in the blood located? It is located in aortic bodies, in the aortic arc, carotid bodies, and the common carotid artery. And this is my last report, and I'm going to pass the floor to Felicity De Carlo. Thank you.
Thank you so much, Mr. Faisal Bayani. Let us move on to the part 3 where we see the respiratory care modalities. So identify the following items used in oxygenation. Please refer on the screen for the illustrations. So this is the nasal cannula. It is a low flow system and a small flexible tube containing two open prongs intended to be placed inside the nostril. The maximum oxygen concentration is 24 to 40% oxygen. The flow rate is 1 to 6 liters per minute. It is used to deliver oxygen when a low or medium concentration is required and the patient is in a stable state. The number two is the face tent mask. It is a low flow system and a shield like device that fits under the patient's chin and encircles the face. The maximum oxygen concentration is 28 to 100% oxygen. The flow rate is minimum of 15 liters per minute. To provide a controlled concentration of oxygen and increase moisture for patients who have facial burn or a broken nose or who are claustrophobics. The third one is the simple face mask. It is a low flow system made of plastic and shaped to fit over the mouth and nose with a port at the bottom for the connection of oxygen tubing. The maximum oxygen concentration is 40 to 60% oxygen. The flow rate is 60 to 10 liters per minute. It is this used to provide a moderate oxygen concentrations. It is also used and are effective when patients require a high percentage of oxygen. Next, please. So the partial rebreather mask. It is a high flow system and a face mask that covers both the nose and the mouth. It has one two-way valve connecting the mask and the reservoir bag in which exhaled air gets into the bag or flows into the atmosphere. The maximum oxygen concentration is 50 to 70% oxygen. The flow rate is minimum of 6 liters per minute. This delivers oxygen therapy for people or short-term patients who need high concentration oxygen but don't need help breathing. Next is the non-rebreather mask. It is a high-flow system that consists of simple mask in a small reservoir bag attached to the oxygen tubing connecting to the flow meter. It has a series of one-way valves between the mask and the bag and the covers on the exhalation ports. The maximum oxygen concentration is 60 to 80% oxygen. The flow rate is 10 to 15 liters per minute. This allows the patients to receive a higher concentration of oxygen used after traumatic injury, smoke inhalation, or carbon monoxide poisoning to keep blood oxygen levels within a normal range. So, to continue the report, I'm passing the floor to Ms. Caspilio.
Thank you, Mr. Carlos. So I will continuing. Venturi mask, or also known as air entertainment mask. It is a high-flow device consisting of a bottle of sterile water, corrugated tubing, a drainage bag, air oxygenation system, and a mask that works with the corrugated tubing. Maximum oxygen concentration is to 25 to 50% oxygen. Flow rate is 4 to 15 liter per minute. It is useful in COPD patients where precise measurements of oxygen prescription is crucial. It delivers humidified oxygen for patient comfort and does not dry mucous membranes. Next is the transtracheal catheter. It bypasses the upper airways and is delivered through a catheter in the trachea. Maximum oxygen concentration is to 50 to 75% oxygen. Flow rate is greater than 4 liters per minute. It uses to deliver oxygen directly to the lungs. It can reduce the amount of oxygen flow needed at rest and with exercise, as well as reduce the symptoms of shortness of breath and improve mobility. Next is the high flow nasal cannula. It is a high flow source with system regulating the flow and the FiO2 or the fraction of inspired oxygen, a humidifier system and heated tubing. Maximum oxygen concentration is to 21 to 100% oxygen. Flow rate is 30 to 60 liter per minute. It used to help reduce the effort of the body needs to put into breathing. It is used for community-acquired pneumonia, post-extubation, and patients with respiratory failures. So this is end of my part. I will passing the floor to Miss Debbie Capitan.
Thank you, Miss Caspilio. For this part, we are going to identify the parts and purpose of such parts presented in the picture below. So, for the first part of this section, we have the oxygen gauge. So, this oxygen gauge regulates required oxygen pressure when an oxygen tank or cylinder is used in oxygen therapy. Next, number two, we have the flow meter. The flow meter is used to measure linear, non-linear, mass, or volumetric flow rate of a liquid or gas. Number three, we have the flow control valve. This flow control valve regulates flow or pressure of a fluid. It responds to signals generated by independent devices like flow meters. Number four, we have the cannula tubing. So this cannula tubing is a thin tube that links an oxygen source to a patient for the delivery of oxygen therapy. Number five, we have this humidifier bottle. This humidifier bottle is used to humidify oxygen, increases humidity or moisture, and decreases dryness of supplemental oxygen during therapy and emergencies with the oxygen supplying system. And lastly, for this part, we have the oxygen tank itself. So this oxygen tank, it facilitates the transport and storage of oxygen gas for medical breathing at medical facilities and at home. So, what are the indication and contraindications of oxygen therapy? So, we all need to know this in order for us to use the oxygen therapy properly and correctly. For the indication, we have the diseases such as asthma, the COPD or chronic obstructive pulmonary disease, the bronchitis, the sepsis, the anaphylaxis, the major trauma, the sarcoidosis, the pulmonary fibrosis, cystic fibrosis, etc., hypoxemia, increased breathing, and hemodynamic insufficiency. For the contraindication, we have the trauma before C-spine clearance, paraquat poisoning, high fever because it may cause seizures, usage of disulfiram or bleomycin, untreated pneumothorax, and patients with unfavorable ventilation due to the reaction to treatment. And lastly, what are the nursing considerations for oxygen therapy? So, as part of the nurse's duty, they must ensure to optimize oxygenation at the pulmonary and cellular level. This requires a thorough understanding of respiratory and cardiac physiology and selecting suitable supplementary oxygen therapy equipment and method. They may they must also identify factors that can compromise oxygen delivery and document baseline observation for saturation, respiratory rate, blood pressure, pulse, and level of consciousness. Moreover, nurses must promote oxygen safety since it is a highly combustible gas. They must check oxygen level of the tanks to ensure there's enough oxygen and look for signs of atelectasis or oxygen toxicity. Oxygen therapy is a medication and can only be adjusted by healthcare providers' order. Thus, nurses must clearly monitor and assess oxygen therapy at regular intervals. So, for the deep dive part, we will be presenting you a video that demonstrate on how to assess respiration. So this video is made by Ms. Sofia Altera Bermejo.
In a assessing a patient's respiration, first you need to check for factors that can affect respiration, such as exercise, anxiety, acute pain, smoking, and medication. What am I going to do is first I'm going to put a pillow at the back of the patient. Second, I'm going to check the patient's respiratory rate. Third, I'm going to help the patient in sitting or lying into a comfortable position. After that, I'm going to make sure that the patient's chest is visible. Next is to place the patient's arm in a relaxed position across the lower chest or upper abdomen. While assessing the patient's pulse, simply place your hand directly over the patient's lower chest. Observe a complete respiratory cycle of one inspiration and one expiration. Then look at your timer or watch. Begin taking the respiratory rate, counting 1 with the full respiratory cycle. If the respiratory cycle is regular, then count it for 30 seconds and multiply the number of breaths by 2. The respiratory rate normally ranges from 12 to 20 breaths per minute. Count the breath for a full 60 seconds. As you count the rate, note the depth of the respiratory by observing movement of the chest wall. Exertion or auscultate in the posterior thorax. Describe whether the depth is shallow, normal, or deep. Also note that the respiratory rhythm, which should be regular and uninterrupted except for an occasional sigh. Observe for dyspnea and ask the patient to compare any shortness of breathing. My patient's result in assessing her respiration is 14 breaths per minute, and it belongs to the normal respiratory rate.
So that's it for our reporting. Thank you for listening and watching. If you have questions and clarifications, feel free to contact us or comment below. Once again, we are the Group 2 from the DCBSN 111F. Thank you and have a nice day ahead.